Hello everyone, welcome to another episode of Clinical Case Discussion. We are going into the third episode of thyroid case discussion. So, in the previous video, we have completed till history of present illness. So, let's continue. Past history. What is the importance of asking past history in case of a thyroid swelling? See, basically, just for any other case, for the completion's sake, we will ask about history of similar complaints in the past. Why? To rule out recurrence. Then coming to medical history, please go and watch Introduction to Case Sheet Writing video, where I have explained about all the importance of each thing in medical history and how it is important for our thyroid case is that thyroid is a very vascular organ. So if there is uncontrolled hypertension, there may be chance of very severe hemorrhage. And coming to surgical history, it is very important to ask about history of any previous surgeries, especially within the thyroid gland, again to rule out recurrence. Okay, right, next. Coming to family history, the question will be what are the conditions in thyroid which will run in families? So, to understand that, we will be dividing it into two things. One is benign conditions, second one is malignant conditions. So, the first one is benign conditions. First one is dysharmonogenesis, where the goiter will be happening because of the enzyme deficiency. And the second entity is also more or less the same thing, enzyme deficiency. What enzyme will be deficient means usually there will be thyroid peroxidase enzyme deficiency will be there. Next, Graves' disease. Again, it is one of the most important diseases which can run in families. Then autoimmune thyroiditis. Coming to malignant diseases which can run in families. All the malignancies of thyroid can run in families, but most important is your medullary thyroid cancer in the form of MEN syndromes. And they'll ask you about little bit about MEN syndromes like multiple endocrine neoplasia. What are the main important MEN syndromes is that MEN 1, MEN 2A, MEN 2B, which is also called MEN 3, and the last one is MEN 4. Okay, so MEN 1 is also called Werner syndrome. Please understand it is M, not N. So Werner syndrome is a different entity where it is more related to progeria, premature aging, etc. Okay, now coming to MEN 2A syndrome, it is also called Sippel syndrome. MEN 3 is little bit, the name is not required for undergraduates, it is more important for postgraduates. They may ask you the name of MEN 3, that is nothing but Wagenman Frobos syndrome. Right, next. So what are all the entities which will be grouped under multiple endocrine neoplasia? As the name itself says, multiple endocrine glands are involved. So what are the things that are involved in MEN1? So you can remember with the help of a mnemonic, PA P. So PA P. So first PA is for pancreatic endocrine tumors. Second one is parathyroid, especially adenoma. Then P is for pituitary. Okay, right, next. MEN2A, again, multiple endocrine. What are the things that are involved is one is thyroid, that is multiple medullary thyroid cancer. Next one is parathyroid in the form of parathyroid adenoma. Then megacolon, pheochromocytoma. Okay, so here this megacolon is something related to is nothing but your ret oncogene mutation. Okay, right. Next, pheochromocytoma in the adrenal gland. Coming to MEN2B, it is very easy to understand MEN3. Please understand this is 3, right? Just keep it little bit oriented, change the direction. You can see it all will be M. So one is medullary thyroid cancer, second one is medullated corneal nerve fibers, mucosal neuromas like this. You can see here the example is tongue here. Next is Marfanoid syndrome. Last one is megacolon. So all M's will be there in MEN3, which is also called MEN2B, right? So MEN4 is nothing but it is just as same as the MEN1. In addition to thus, there will be adrenal, renal, and reproductive organ tumors in case of MEN4. So, MEN1 plus all these three things will be grouped together and called MEN4. Okay, right, next. Personal history. Very, very important to understand personal history. Few important questions they can ask you is first one, what are the important dietary goitrogens? Goitrogen is nothing but a substance which will cause goiter. So you know the classical answer is Brassicaceae family like cabbage, cauliflower, etc. So Brassicaceae family. Apart from that, you have mustard oil, sweet potato, etc. Okay, next. Another question they will ask you is regarding the diet. We should ask the patient what type of salt they use. and the examiner will specifically ask you what is the name that you have asked, means it is rock salt. Okay, like the crystal one, it is the crystal salt. Okay, right. Next one, why are you so worried about diet? You know that iodine is very essential for uh, thyroid hormone synthesis. Iodine is very essential for thyroid hormone synthesis. So the one question they can ask you is what is the normal recommended allowance of iodine? So you need to remember, in children it is somewhere around 50 micrograms. In adults, somewhere around 100 to 150. And in pregnant and lactating females, it is 200 mcg. Okay, it is another important question they can ask you. So here, how do the brassicaceae family people, like they, how do brassicaceae vegetables cause goiter? Means these vegetables contains thiocyanides. Okay, so that is nothing but perchlorates and pertechnetates. Please go and watch the video of important concepts in thyroid, where I have explained why this is important and how they cause inhibition of thyroid hormone synthesis. Okay, right. Perchlorates and pertechnetates. Now, another important question they can ask you is, apart from the dietary goitrogens, what are the other important goitrogens we have? So, goitrogens is nothing but a substance which causes inhibition of thyroid hormone synthesis. So, one is diet, second one is drugs, third one is smoking. We will see in the last heading in this slide only. Okay, right. So, appetite. Please understand what is the relation of appetite in case of a hormone like thyroid dysfunction is that in hypothyroidism, there will be weight gain. There is nothing much to do with your appetite. Even in hyperthyroidism, there will be normal appetite. But because of the increased basal metabolic rate, because of the increased basal metabolic rate, there will be weight loss. Okay, right. Only in case of malignancy, you can expect a decreased appetite. Now, coming to sleep pattern, I told you in case of hypothyroidism, there will be very lethargic and excessive sleepiness. Whereas in hyperthyroidism, there will be insomnia. Patient will not be able to sleep. Right? So bowel and bladder habits we have already discussed in previous video. And now coming to addictions. One important point you should understand is smoking. So let's say, for example, the lady comes and says, Doctor, I follow everything. I take iodinized diet and I follow every single dietary thing, but still I have got goiter. What is the explanation? Ask them very one simple question, that is, do you smoke? If the lady says, yes, doctor, smoking itself is a predisposing factor for goiter. How? Please understand. Again, please go and watch Introduction to Case Sheet Writing, where I have explained the three most important components of smoking are hydrogen cyanide, carbon monoxide, and nicotine. So, this hydrogen cyanide, whatever the cyanide component is there in smoking, the cyanide itself is the inhibitor of Na plus and I minus importer. Okay, that's how it will inhibit the thyroid hormone synthesis and it will result in goiter. Okay, that is the explanation, right? Coming to menstrual history, we have already seen that thyroid dysfunction and menstrual function have got inverse relation. So, in case of hypothyroidism, there will be polymenorrhea or menorrhagia. So, these are the important things that you should remember. One important point, one word you should understand is alpha chain. So, TSH and FSH has got common alpha chain, right? Next. So marital history, one important question that you need to ask the patient is whether patient had got any infertility and any treatment had been taken. Why? Infertility itself is a hormonal imbalance condition. It's a condition of hormonal imbalance. So one thing can lead to another. That is why whenever a couple comes to infertility clinic, the first test, one of the important tests that will be ordered is thyroid profile. Okay, right. Next. Coming to others, treatment history and allergy history. In treatment history, they'll ask you one question. The examiner can ask you, how can you differentiate? Like, how can you ask the patient whether she is on thyroid drugs or anti-thyroid drugs? So please understand, thyroid drugs, nothing but most commonly levothyroxine will be taken. So levothyroxine is usually taken once daily before breakfast, single dose. Whereas antithyroid drugs can be taken BD or TAD depending upon severity, and usually it will be after food. That is how you can ask the history, right? Next. Coming to general examination, so you need to understand one important point. These are all part of general things which we have discussed in introduction to case sheet writing. So if you have got any enlarged lymph nodes in general examination, you can simply tell, sir, there is generalized lymphadenopathy is a different entity where there are enlarged more than or equal to two non-contiguous group of lymph nodes are involved. So, if you see any enlarged cervical lymph nodes, just mention one simple sentence. There are visible cervical lymph nodes, sir, that I will be describing in inspection in local examination. Okay, right. So, coming to vital data, what is the significance of temperature? You know that thyroid hormone will increased basal metabolic rate, so that can cause rise in temperature. So, rise of temperature may be there. Okay, whereas in hypothyroidism you can expect little bit hypothermia. And one question they can ask you here is that what is labor master rule? Labor master rule, it is nothing but with 1 degree Celsius rise in temperature, it can cause few changes in the body. So that is, so it can cause 7 cycles per minute respiratory rate and 10 mmHg rise, and pulse rate can go somewhere around 13, and it can go somewhere around 15% increase in partial pressure of oxygen. Okay, sorry, it is 5, 7, 10, and 30. Okay, so with 1 degree Celsius rise in temperature, your respiratory rate can go somewhere around 5 to 6 beats per minute, and 7 millimeters mercury BP will be increased, and 10 will be your pulse rate, and partial pressure of oxygen will be increased somewhere around 13 to 15. Okay, right, that is Leibermeister rule. Another one is pulse. Please understand, regarding the pulse rate, you know that in generally in case of hyperthyroidism there will be increased pulse rate, that is tachycardia will be there. In hypothyroidism there will be bradycardia. One important question they can ask you, what is the mechanism behind the tachycardia, is that basically thyroid hormone in heart, it will increase the number of beta 2 receptors, and also it will increase sensitivity to these beta 2 receptors, increased sensitivity to catecholamines. This is the mechanism how thyroid hormone will increase the tachycardia. Okay, and coming to blood pressure, basically thyroid hormone will cause widening of the pulse pressure. What do you mean by that? Widening of pulse pressure. So pulse pressure is nothing but systolic BP minus diastolic BP. So thyroid hormone will increase systolic BP and decreases diastolic BP. That is why there will be increase in pulse pressure. That is called widening of the pulse pressure. Okay, right. Another important thing they can ask you regarding the pulse is that what is sleeping pulse rate? So another important question they will ask you is what is sleeping pulse rate, and Kryl's grading of sleeping pulse rate. Please understand, when you are presenting the case in the examination, you cannot comment about sleeping pulse rate because you are checking the pulse in awakening state of the patient. So, if at all the examiner asks you what is sleeping pulse rate and what is the Kryl's grading, you need to go. Usually, it is checked in deep sleep somewhere around after. If or otherwise, you can go for any sedation tablet, and you can check the sleeping pulse rate. So you can they can be asked about Kryl's grading. So there are three important grades of Kryl's grading. So 1, 2, 3. When the pulse rate is 90 to 110, sorry, less than 90 is grade 1. So 90 to 110 is grade 2. More than 110 is grade 3. Okay, so that is Kryl's grading of sleeping pulse rate. Now, coming to any other finding specific to the case means you need to mention two important things. One is any signs of hypo or hyperthyroidism. You need to check the patient top to bottom and tell whether there are any signs of hypo or hyperthyroidism, and specifically if there are any signs of hyperthyroidism you need to make a comment about eye signs. So eye signs of thyrotoxicosis. These are the things we should remember in general examination related to thyroid case. Well, okay. Now we have seen the symptoms of hypo and hyperthyroidism. In this slide, we will more focus about the signs here. So again, you can remember from top to bottom. I told you when it comes to head, you can see the patient will be very lethargic, confused, and there will be lusterless hair. And when you look at the face of the patient, there will be facial puffiness, and the lateral one third of the eyebrows and eyelashes will be lost. That is called madrosis. And when you look at the tongue, there may be glossomegaly, glossomegaly or tongue edema. And you, at the level of neck, there will be usually goiter. And when you check the pulse of the patient, obviously we will be having bradycardia in case of hypothyroidism. And when it comes to general things, patient will be very obese. Just by looking at the patient, you can tell whether this patient is a hypo or hyperthyroidism. In case of hypo, there will be obesity, whereas in case of hyperthyroidism, patient will be very thin. Okay, and when you check the skin of the patient, it will be dry and inelastic. Normally, to maintain the integrity of the skin, thyroid hormone is very essential. When there is hypothyroidism, there will be loss of that integrity, and it will lead to dry and inelastic skin. And there will be increased skin thickness, that is called pachyderm. Okay, right. And when you check the reflexes of the patient, we'll be talking more about this in nervous system examination. There will be sluggish reflexes, and there will be pseudomyotonic reflex. That is nothing but hung up reflex. Okay, so it will be something like very slow reflex. Another important question they will ask you regarding the sluggish reflexes is that please understand usually reflex has got two phases, contraction phase and the relaxation phase. What happens in hypothyroidism is that usually this relaxation phase will be prolonged. That is why there will be delayed or sluggish reflexes. So this relaxation phase of the reflex will be very much increased. Okay. Now coming to hyperthyroidism signs. So just by looking at the patient, you can see the patient will be very restless, very anxious, full of sweating on the forehead, etc. And when you look at the eyes, there will be named signs. We will discuss that in subsequent slide. Next slide. So when you check for the tremors in the patient in the tongue, I'll show you this image. There will be tongue tremors, and in case of hyperthyroidism in CVS, there will be tachycardia, or rarely you can get murmurs. And coming to limbs, you need to check for the hand tremors. And when you give shake hand to the patient, there will be hot and sweaty hands. This is one important point. The examiner will ask you how will you differentiate between hyperthyroidism and sympathetic overactivity. If it is something like when you give shake hand to the patient, if the palm of the patient is cold and sweaty, it is sympathetic overactivity. Whereas if it is hot and sweaty, it is hyperthyroidism. Okay. And when you check the nails of the patient, there will be clubbing. That is called thyroid acropathy. And there will be pretibial myxedema. Okay. And there will be profuse sweating. Just by looking at the patient, you can appreciate this patient is in hyperthyroidism. Okay. Now, next one. Coming to thyroid ophthalmopathy, what is the basic mechanism behind thyroid ophthalmopathy? Right? We will see the concept. Please understand, in case of Graves thyroid disease, that is Graves disease, the main mechanism will be little bit autoimmune disease, where there will be autoantibodies against TSH receptor. TSH receptor. So autoantibodies are developed against this TSH receptor. Because of this autoimmune mechanism, inside the eye, what is happening is that there will be increased muscle infiltration by T cells, etc. And along with the T cells, there will be fat infiltration, and also there will be infiltration of accumulation of glycosaminoglycans. You know, these glycosaminoglycans or polysaccharides, they have the propensity to retain the water. So they will cause retention of water. So whenever there is a increased glycosaminoglycans within the extraocular muscles, there will be increased extraocular muscle hypertrophy. So slowly there will be fibrosis, and there will be decreased activity, and also this uh, eyeball is pushed forward. So there will be exophthalmos. Why? Because of the retroorbital fibrosis. Retroorbital fibrosis also will be happening. Okay, so there will be exophthalmos. What happens whenever there is prolonged exophthalmos? So there will be dryness of the conjunctiva and edema of the conjunctiva also. That is nothing but conjunctival ingestion. Okay. So at one point of time, this conjunctival ingestion, there will be dryness and there will be keratopathy. Okay. So exposure keratitis will happen. Exposure keratitis will happen. And in the last stage, usually this exposure keratitis, the last stage will be something, there will be permanent eye changes. Like even there will be loss of sight also. Permanent eye changes. Okay. This is the spectrum of thyroid ophthalmopathy. And there is one important classification for the thyroid ophthalmopathy that goes by the name modified Werner classification. Please understand it is Werner. So the mnemonic is no specs. So first one is class 0, there will be no signs or symptoms. In class 1, there will be only signs but no symptoms. And S is for soft tissue involvement. How? In the form of edema of the conjunctiva, conjunctival injection. Then 3, P is for proptosis more than 20 mm. Please understand, exophthalmos up to 8 mm, 18 mm is normal. So if it is more than 20 mm, there will be pathological things. Okay. Then class 4 is E. E is nothing but extraocular muscle involvement. How? There will be limitation of the movements, and the next stage will be diplopia. Why is there limitation of movements? Because of the muscle fibrosis again. Okay. Now after that, there will be corneal involvement in the form of exposure keratitis. I told you. And lastly, there will be sight loss due to optic nerve involvement with papillary edema, etc. Because of those things, there will be even sight loss also. So this is the severity of the thyroid ophthalmopathy, right? Next. So there will be named signs in case of thyroid ophthalmopathy. These are the named signs. So first one is Geoffroy sign. You can remember from top to bottom again. So first one is Geoffroy sign. You will ask the patient to look up. Normally there will be wrinkles on the forehead, but there will be absence of forehead wrinkling in case of thyroid ophthalmopathy. That is Geoffroy sign. Now, normally upper one third of the sclera is not visible in you and me. But in case of thyroid ophthalmopathy, because of the exophthalmos, there will be exposed upper sclera. So that is visibility of the upper sclera is called Dalrymple sign. Right? Next. So this bilateral proptosis can give you a staring look. That is called Stellwaxen. You can remember S for Stellwaxen, S for staring look. Right? Next. Another one is Van Graef sign. So it is nothing but lid lag. How will you check for this lid lag? You will ask the patient slowly. First, you will ask the patient to look at the center. Then slowly you will ask the patient to follow your finger upwards and downwards. When the patient is trying to look downwards or even upwards, there will be little bit lag of the abnormal side, that is called lid lag, which is called Van Graef sign. Right? Next, Mobius sign. What do you mean by Mobius sign? How will you check for this? See, normally you will ask the patient, you will sit in front of the patient and you will ask the patient to look at a far point. And then you will keep your finger in front of the eyes and you will ask the patient to shift his vision from far vision to near vision. So normally when there is a shift from far vision to near vision, there will be convergence of the eyeballs. But in case of thyroid ophthalmopathy, this convergence of the eyeballs is lost. So the failure of convergence of eyeballs is called Mobius sign. Okay. Whenever there is a change in far vision to near vision, right? These are the named signs in case of thyroid ophthalmopathy. 5 important things. Another important named thing they can ask you is Navziger's test. It is to check for the exophthalmos. You will go and stand behind the patient and you will check whether there is any forward protrusion of the eyeball. I'll show you the pictures. Okay. So this is the important table you should understand. Because of the increased adrenergic activity, the named signs will be, one is lid retraction, lid lag sign, that is nothing but Van Graef sign, Dalrymple's, nothing but visibility of the upward sclera. So you can see here, this is the visibility of upward sclera. Then Stellwaxen is nothing but staring look. So you can see here, this is the staring look the patient is having. Then next one is Geoffroy sign. I told you it is nothing but absence of wrinkling. Okay. Then coming to Mobius sign. Mobius sign is nothing but absence of convergence of the eyeballs. Okay. Last one is Navziger's test. So this is how you will check for the Navziger's test. You can appreciate the exophthalmos here in Navziger's test in this patient on left side. Okay. Right. Another important question they can ask you is, what is the main difference between exophthalmos and proptosis? More or less the mechanism is same, but the terminology is little bit different. When it happens in thyroid ophthalmopathy, thyroid disease, that is called exophthalmosis. When it is happening other than thyroid disease, it is called proptosis. Okay, right, that is one important basic difference. Now coming to how will you check for hand tremors and tongue tremors. One important point I want you to remember is, what are the important muscles we are checking for? It is mainly intrinsic muscles of tongue and intrinsic muscles of hand. So to check either of the things, first you should especially to check for the tremors of hand, you will ask the patient to sit down calmly and switch off the fan in that room, and you will ask the patient to close the eyes, because in awakening state the patient may try to balance the things when he is looking at that particular thing. That is why you will ask the patient to close the eyes, and ask the patient to stretch the hands like as shown in the figure here, and you should ask the patient to do the fanning of the fingers. Now you will check whether there is any shivering of the hands here. The other method is that you will keep a piece of paper on the dorsum of the hand. So you should ask the patient to keep it in prone position. Why not in supine position? Because it is difficult to balance the posture in this manner. That is why you will ask the patient to keep the hand or forearm in prone position. Okay, so you will keep a piece of paper on the dorsum of the hand, and you will check whether there is any movement of the paper. If there is so, it indicates hand tremors are present. Another thing is, how will you check for tongue tremors means, one important point you should understand is, you will ask the patient to keep the tongue within the oral cavity. So tongue should be within the oral cavity. Why? What happens if the patient keeps the tongue out? Please understand, at the outset we have told mainly we are checking for intrinsic muscles. So what happens whenever there is protrusion of the tongue? For the protrusion of the tongue, one important muscle that is required is geniohyoid, or sorry, genioglossus. So this genioglossus is a extrinsic muscle of the tongue, but you don't want to check for the extrinsic muscle of the tongue. We are checking mainly for intrinsic muscles. Why only intrinsic muscles? Again, you need to understand the mechanism. Normally thyroid hormone is essential for the proper response of free nerve endings or receptors. Whenever there is increased thyroid hormone, there will be increased sensitivity of this free nerve endings. That is why there will be tremors. That is the mechanism behind why thyroid hormone increase will cause tremors. Okay, so you should not check the tongue tremors in the forward protruded position, because it will cause one of the extrinsic muscles of the tongue, that is nothing but genioglossus, will come into action. That is why you should always check for the intrinsic muscles. Okay, right.